Let's be real for a second. Trying to connect embryology to what you actually see in the clinic can be a total nightmare, especially when you're staring down your final exams. But that exact link, the one between a tiny error in development and a full-blown clinical presentation, is exactly what examiners love to test. So in this explainer, we're going to bridge that gap and turn these tough topics into easy marks for you.
Okay, let's jump straight into a classic case. You're in your Viva, right? The examiner gives you this scenario. A teenager who gets cramping pain every month, like a period, but she's never actually had one. What is going through your head? This picture is just screaming one specific diagnosis. Hold that thought, because by the end of this, you'll nail this question and all the follow-ups with total confidence.
So here's our game plan. We'll kick things off with obstructive anomalies, which, hint hint, is the answer to our case. Then we're going to untangle the Mullerian duct malformations. After that, we'll lay out a simple timeline for puberty and its disorders. And we'll wrap it all up with the absolute gold, the high-yield exam points you just can't afford to forget.
Right, Section 1. Let's talk about what happens when the exit is blocked. These are conditions that, they usually fly under the radar until puberty hits. That's when menstruation starts and the problems start to build up, quite literally.
The number one cause, and the most likely answer to our opening question, is an imperforate hymen. Embryologically, it's actually pretty simple. A membrane that was supposed to break down before birth just didn't. It happens in about 1 in 1,000 girls, so you're very likely to see it on an exam. Remember, she has a normal uterus, normal ovaries. She's making menstrual blood. It just has absolutely nowhere to go.
And this is the result. This diagram shows it perfectly. As that blood collects month after month, it first fills up and stretches the vagina. We call that hematocolpus. Then it starts backing up into the uterus. That's hematometra. And in really severe, late cases, it can even spill into the fallopian tubes, causing a hematosalpinx. This collection of blood is what creates that suprapubic mass you can feel, and it's what's causing all that pain. You can also see how this massively swollen vagina can press on the urethra, which is why she might have trouble peeing.
But wait, here's a classic exam trap. The presentation could also be a low transverse vaginal septum. Clinically, it looks and feels almost exactly the same as an imperforate hymen. The only real difference is where the blockage is. You have to remember this differential. It tells the examiner you're thinking one step ahead.
Okay, now let's level up. We're moving from a simple blockage to much more complex problems with the architecture of the uterus itself, the Mullerian duct anomalies. Everything that goes wrong here really just boils down to a problem with one of 3 key steps: formation, fusion, or resorption.
So the most important thing is to get the 2 main failure types straight. Just think of it like a zipper. On the left, you've got fusion failure. The 2 sides of the zipper, those are your Mullerian ducts. They never zip up properly in the middle. This gives you things like a bicornuate or heart-shaped uterus. Now on the right, you've got resorption failure. Here, the zipper closes just fine, but the bit of fabric behind the teeth, the septum, is never removed. So you're left with a wall running down the middle. And that gives you a septate uterus.
This classification system is a fantastic visual summary of everything that can go wrong. You can see class I, agenesis, where things just don't form at all. Then you see the results of fusion failures, like the unicornuate, didelphys, and bicornuate uterus. And finally, the result of a resorption failure, the septate uterus. It lays out the whole spectrum beautifully. Now let's zoom in on the 2 that everyone gets mixed up. Septate versus bicornuate. In your Viva, you will be asked to tell them apart. And the absolute key is the external contour of the uterus. A septate uterus looks completely normal from the outside. The problem is all internal. A bicornuate uterus, on the other hand, has that classic heart-shaped dip on the top. This one difference changes everything about management. You can easily remove an internal septum with a hysteroscopy, which massively improves pregnancy outcomes. But fixing a bicornuate uterus is a big, open surgery that's hardly ever done.
So what if the uterus is just gone? That brings us to MRKH syndrome. After Turner's, this is the 2nd most common cause of primary amenorrhea. So what do you have to remember? 1. The patient is genetically female, 46XX. 2. She has normal, working ovaries, so she develops breasts and pubic hair just fine. But 3. She has no uterus and no upper vagina. The huge take-home point for your exams: always check for other problems. About 40% of these patients have urinary tract defects, and about 12% have skeletal issues.
Okay, so we've covered the structural problems. Let's switch gears to the functional side of things, the puberty timeline. You've got to know the normal sequence of events like the back of your hand, because it's the only way you'll be able to spot what's abnormal.
Here's the standard order for girls.
The very first sign, the one that kicks it all off, is thelarche, or breast budding, at around age 10. That's followed pretty quickly by adrenarche, the growth of pubic and underarm hair. Then comes the big growth spurt, and finally, around age 13, menarche, the first period. A simple way to remember the order: breasts, pubes, spurt, bleed.
So what's abnormal? It's all about the timing. We call puberty precocious if things start happening before age 8. The cause can be central, meaning the brain's hormone control center turns on too early, or peripheral, where it's driven by something else, like an ovarian tumor. On the other side of the coin, we call puberty delayed if there's no breast development by 13 or no period by 16. For those cases, we've got to figure out if the problem is with the ovaries or with the brain.
All right, this is it, the final stretch. Let's pull everything together into the most critical high-yield points. This is the stuff that's going to win you marks in your theory papers and your vivas.
These are the traps you absolutely must avoid. First, always mention a transverse vaginal septum as a differential for an imperforate hymen. Second, master the difference between septate and bicornuate, resorption versus fusion, and that all-important normal external contour of a septate uterus. Third, and this is a big one, if you diagnose a Mullerian anomaly, the very next words out of your mouth should be, and I would investigate for renal anomalies, and you should mention that 40% association. And finally, don't forget that hypothyroidism is a great pretender. It can cause both delayed and precocious puberty.
Okay, time for a final rapid-fire recap. If you remember nothing else, remember these 5 points. 1. Cyclical pain plus no period equals an outflow obstruction. 2. You see a Mullerian defect, you check the kidneys. 3. Septate uterus looks normal on the outside, bicornuate is heart-shaped. 4. MRKH patients are genetically female with working ovaries. And 5. The very first sign of puberty is breast budding or thelarche. Get these down, and you've got this topic locked for your exams.